So today we'll be going over MicroPulse Transscleral laser, and we have our special guests here who are experts on the topic. On one side, Ronald De Crom from the Netherlands, and on the other side we have Walid Zbiba from Tunisia. I'll be introducing them a little bit in more length once right before their lectures. And this program will last for about an hour. We will be presenting 3 different lectures, trying to cover the most we can on MicroPulse TLT. And then we will have 20 minutes at least for questions and answers. So I welcome everyone to send their questions via the little chat box. And so the first lecture is about decoding the mechanisms of action of MicroPulse TLT. Just gonna share my presentation now. There you go. Okay. So when it comes to relevant disclosures, I'm a consultant, speaker, and I've received research support in the past from Iridex. And what's the objective of my lecture? It's to review our current knowledge of MicroPulse TLT mechanisms of action to lower intraocular pressure and to compare it with the technique that we are all very familiar with, which is the classic continuous transscleral cyclophotocoagulation. So what is MicroPulse TLT? MicroPulse TLT is a versatile, non-incisional procedure for the treatment of glaucoma performed with the Iridex Cyclo G6 laser and the MicroPulse P3 delivery device. As we know from the literature, depending on the dosage, the technique, and the clinical scenario, intraocular pressure can decrease after MicroPulse TLT from about 30 to 60% and has a sustainable, durable effect. Now, based on this, let's see if we can try to understand a little bit how it actually works. What are the main differences between MicroPulse TLT and the traditional conventional cyclophotocoagulation? Where one of the first differences is where we actually place the probe. When it comes to the traditional CPC, the probe is placed more anteriorly, and it actually has more of an effect over the pars plicata of the ciliary body, as we can see on the left side of the slide. When we look at the right side, that's a MicroPulse P3 probe, and we can see that the laser is aimed more towards the pars plana. So that's the first big differences between both techniques. The second is how we proceed when it comes to delivering the energy. With the traditional CPC, we do discrete spots, as we all know, and with MicroPulse, we do more of a sweeping motion. We can treat either quadrants, or as I'm doing here, we can treat hemispheres. Usually the horizontal meridian is spared to avoid nerves and vasculature, which are more in that location, more present in that location. And as you can see here, also sweep velocity is critical for appropriate delivery of the energy. So this is actually the second big difference between both techniques. Then the most important one, the one that actually, made the difference, was that the MicroPulse technology actually chops a continuous wave laser beam, because both are diode lasers. But with the MicroPulse technology, it's chopped, the laser beam is chopped into short on pulses and off pulses. So the laser is on and off throughout the procedure. The off pulses allow for dispersion of the energy and less heating, actually. And this is just a slide showing the differences, right, that I just described when it comes to the MicroPulse mode and the continuous mode. Because of all this, the energy absorption is pretty different between both techniques. With MicroPulse, you have lower temperature targets, and you have a better thermal control. So the range is much smaller of temperature that you can get with a MicroPulse compared to traditional CPC. This actually leads to one of the main advantages of MicroPulse, which is the lower risk for complications. And this also explains why the indication profile has actually broadened since the development of the MicroPulse mode. And this is a poster we presented in ARVO just recently. It's a thermal modeling of the temperatures that you would get within the target tissues when you use traditional CPC versus MicroPulse. And this figure actually highlights very well those differences. On the y-axis, you can see the temperature that it's being reached. On the x-axis, you see the time it gets to reach that temperature. When you look at the first curve, that's for a continuous wave for the classic settings. And you can see that the temperature that's being reached within the ciliary body goes beyond 100 degrees, which causes significant coagulative necrotic damage. That temperature above 100 actually remains that high for 1 or 2 seconds. And then, the temperature goes down, over time. The second curve that you see is the same continuous wave procedure, but with a slow burn technique. So it takes a little bit longer to reach above 100 degrees of temperature. And when you look actually at the three curves at the very bottom, those are curves, heating curves, caused by MicroPulse treatment. Depending on how fast you do your sweeps, the slower you go, the higher the temperature you reach. You will see that actually the temperature range goes between 60 and 70 degrees, and for actually less time. So from this figure, you can really explain to some extent what would be the consequences or the potential side effects of one and the other. And in the next couple of slides, I'll try to explain the evidence we have so far when it comes to trying to explain the biologic effect of getting those temperatures of 60, 70 degrees on target tissues with MicroPulse TLT. So when it comes to the proposed mechanisms of action, one of them would be decreased aqueous humor production. And this is based on basic science work. Tujisawa, he studied rabbit eyes with that he treated with MicroPulse TLT, and found subtle changes on the mitochondria and the non-pigmented epithelial cells of the ciliary body, right? So there were damaged mitochondria that he could actually, or that group could identify, and there was contraction of the non-pigmented epithelial cells of the ciliary body. Musa and Maslin also found minimal changes at that level, and this to some extent could suggest that MicroPulse TLT would have an effect on decreasing the production of aqueous humor. We know that for sure in the case of CPC, but we weren't that sure in the case of MicroPulse. At least there are some changes within those structures that produce the aqueous humor that would be affected by MicroPulse TLT. Then we have the work by Johnstone and colleagues that have an impact on explaining that potentially MicroPulse TLT may be enhancing the conventional outflow system. And what he actually showed, and we can see on this video below, is that the energy delivered by the MicroPulse would cause contraction of the ciliary muscle, which would pull from the scleral spur and would move actually the scleral spur posteriorly, causing an increased tension at the level of the trabecular meshwork, and also prevention of Schlemm's canal collapse. And we know that that improvement in the function of the conventional outflow system could lead to an increase in aqueous humor draining through that outflow system. And the third suggested mechanism is increased uvoscleral outflow. And this is both supported by some basic science publication and also some clinical work, which I'll be showing now. In the case on the basic science side, Nemoto and colleagues also work on rabbit eyes. They performed MicroPulse TLT on those eyes, and a week after, enucleated the eyes and did significant histologic analysis. And what they saw was that the outflow system, the uvoscleral outflow system, was actually enhanced in eyes treated with MicroPulse TLT compared to controls. And before I get to his work to describing more of his work, I want to mention the following. In clinical practice, usually what we see is that when we treat a patient with MicroPulse, usually within a week, we get a significant pressure reduction that actually, after several weeks down the road, let's say up to 6 weeks, would diminish to some extent. So initially there is a big response, then you lose a little bit of a response, but you still have a significant reduction in intraocular pressure. And that may suggest that there are these different mechanisms of action taking part of that response. And most likely the effect that we see beyond 6 weeks may be more related to inflammation and scarring and remodeling at the level of the outflow systems. And when we look at Nemoto's work, what he actually was able to show was that there was increased metalloproteinase levels in the uvoscleral outflow tract after MicroPulse TLT. But he also saw that the signal for fibronectin, which is a marker of fibrosis, was also much increased, as he could see on confocal microscopy, which would also be in agreement with what we see clinically, what I was just describing before the slide. And then we have this work, which is a prospective work on patients, where Chang Sampech and his group evaluated cerebrochoroidal effusions with UBMs in patients that underwent MicroPulse TLT. And he found that about 50% of those patients had, to some degree, a cerebrochoroidal effusion. As you can see on the right side, you can see different images. He graded it from grade 0, grade 1, where it was like subtle changes, to a significant cerebrochoroidal effusion, as you can see in the grade 4 example. And there was a correlation between the magnitude of that cerebrochoroidal effusion and the pressure reduction. So the bigger the cerebrochoroidal effusion, the more of a pressure reduction you would get. Though after about, I think it was like 12 weeks, I mean, most of the effusions would resolve within 12 weeks. And around that time of the 3 months, there was no more significant difference in pressure reduction between those patients that did have acetylcholine effusion and those that did not. But his findings actually suggest that there is an effect of MicroPulse TLT increasing the UV scleral outflow system in order to lower intraocular pressure. This slide is just a summary of the different outflow systems that actually get affected, or the production of aqueous humor. And this slide here just highlights, I mean, we're just talking about MicroPulse TLT, and we wanted to compare it with conventional CPC. As we were mentioning on the computer modeling with the temperatures, the much higher temperatures that you would reach with the traditional CPC, here you can see an example of the scarring that you get after a traditional CPC, right? I mean, you get very high temperature that causes necrosis, scarring, and this picture is the product of that. Of course, this would also have an impact on the production of aqueous humor, and as was described back in 1994 by the group of Guo Jing, they showed that the scarring would affect the UV scleral outflow system, increasing spaces within those tissues that could potentially facilitate the egress of aqueous humor from the eye. So in conclusion, the data suggests that the effect of MicroPulse TLT on IOP reduction is multifactorial, and this is supported so far by published work on computer models, animal models, cadaver studies, and human clinical studies. MicroPulse TLT seems to have an impact on aqueous humor production, on the conventional outflow, and the UV scleral outflow. So thank you very much. I will now introduce Dr. De Crom. Ron, if you want to upload your presentation. Dr. De Crom is affiliated with the University Eye Center of Maastricht in the Netherlands, where he specializes in glaucoma management with over 8 years of experience using MicroPulse TLT. He has published extensively on the topic. His work has focused significantly on evaluating the long-term results of MicroPulse TLT, and also on developing best practices for MicroPulse TLT. He will be enlightening us today with his lecture on those topics.
Yeah, thank you, Thomas, for your introduction. And also, I have some consultancy and some lecture fees in the past from Iridex. Nowadays, of course, we've got a lot of different glaucoma treatments. So it isn't alone the eye drops and the SLT or the traps or the tubes, but especially the last couple of years, we've got some more developments like the minimal invasive procedures, but especially, of course, in an upgrade in the ciliary body procedures. And Thomas just mentioned the system in which you can perform both the continuous wave mode and the MicroPulse mode. And here again, you can see the difference between the two modes. So the continuous wave pulse with a continuous wave pulse with a long duration in comparison with the MicroPulse mode, in which the energy is on and off between the modes. And if we look at the continuous wave mode can be used especially in patients with more advanced or end-stage glaucoma disease, with a poor vision or poor visual potential, and also with in patients with a lot of medications and still high intraocular pressures. With the MicroPulse mode, we've got some more patients categories we can treat. For example, patients with a mild or moderate disease, also patients with better visual acuity, you can treat with them. And besides the milder diseases, still the advanced and end-stage diseases can be treated very well with the MicroPulse mode. And the last couple of years, a lot of literature became available about the MicroPulse treatment. And if we look at the literature, something is always very important with glaucoma treatments, and that is the long-term efficiency of a treatment. And if you look in the literature, and especially the literature about the MicroPulse TLT treatments, there is a lot of publications about a couple of months or year outcomes. And these are 3 articles with 2-year clinical outcomes. And one is from our own group. We investigated the treatment outcomes after 2 years. Another study is done by Chen et al. In a Taiwanese population, and Kan et al. They've published the outcomes of 2-year follow-up in a Canadian population. And if we look at these 3 studies, we can see that in our own population study, after 2 years, we still found a very good IOP reduction of almost 30%. And it went together with also a very significant medication reduction. And what we also found was that almost 80% of the patients could stop with their oral acetazolamide. So in this patient category, that were very good results. And because of the MicroPulse mode, we also saw very little complications. If you compare it with continuous wave mode, it was a very, very safe procedure. If we look at the study of Chen et al., they found a higher IOP reduction, more than 46%, in combination with a significant medication reduction. And also they found that the procedure was very safe in their patient population. And if we look in the Canadian population, they also found a significant IOP reduction of almost 30%. And in their population, around 2/3 of the patients could stop with the Diamox. So if you look at the efficiency of the MicroPulse and the outcomes after 2 years, we can say that you can get an IOP reduction up to 46%. And there is also a good medication reduction and a great chance of discontinuing the use of oral acetazolamide. And besides that factors, you can safely perform it in your patients. But it's still only 2 years. So fortunately, there are some promising longer-term data on the way. And these are some preliminary data of our own big MicroPulse database. And this is up to 4-year follow-up. And we still see in this population and that during the 4 years, the IOP remains very stable. So we found a significant IOP reduction of some 30%, in combination with also a significant medication reduction, and more than half of the patients could stop with the use of Diamox. And it still remains a very safe procedure. So the use of MicroPulse TLT can lead to a very sustainable IOP reduction and also medication reduction. But how do we get this good results with the treatment? The most important thing, of course, is that you select the proper patients in which you want to perform the treatment. And Thomas already mentioned the consensus panel. We've published the guidelines 2 years ago. And patients who are very suitable for the surgery are patients, for example, who aren't suitable for incisional surgery. For example, patients with bad conjunctival tissue, patients with complicating factors like aphakia, or patients which are not able to undergo a bigger incisional surgery. That are all very good patients to consider treatment with MicroPulse TLT. Also, people who already received some glaucoma surgery, for example, a trabeculectomy or a tube implant, they are very suitable patients to perform the MicroPulse TLT. And for example, to get some better IOPs or to lower the use of glaucoma medications in these patients. You can also consider it if you want to bridge some time on the way to bigger glaucoma surgery, but also patients who are stable but are on a lot of medication. You can use the MicroPulse TLT in order to reduce the number of medications. But because it's a small and safe treatment, you can also consider it in other patients, but especially if, of course, topical medication or SLT laser treatment is already been done or already has been considered. But yeah, for all the patients you treat, it is important to know that it's just like glasses or intraocular lenses. Also with the MicroPulse TLT, one size does not fit all. You have to think about the settings because Thomas just mentioned the settings you use, they are very important for the treatment effect you can reach. So with our consensus panel, we recommend some starting settings if you want to start with the treatment. And the starting settings, they are mentioned here on the slide. You can see a 2500 milliwatts and then fixed duty cycle and 4 sweeps of 20 seconds per hemisphere. And I think these are the minimum settings. And this is very important because if you perform some treatment, it is very important that you see what type of patients you want to treat. For example, you can make some changes in the settings. You can increase, for example, the power, you can decrease the sweep velocity, and you can increase the number of sweeps. So I will give some examples of other settings you can use. For example, you can use the advised power at 2500 milliwatts, the fixed duty cycle, but you can add some sweeps for your treatment. For example, you can perform 6 to 8 sweeps of 20 seconds per hemisphere. Another way to adjust your settings is to make slower the velocity of the sweep movement. For example, so you can perform 4 sweeps with a sweep velocity of 30 seconds. And it's all depending on patient-related factors. So for example, if you've got a patient with a very high intraocular pressure, you can adjust the number of sweeps, or you can decrease the sweep velocity. We also know that there is a good chance that within 1 year you can get good results in the patients you treat. And also with second treatments, there is a good chance that you can get some good results. And for example, if you consider some retreatment, it depends on the effect of the first treatment. So if the first treatment was very successful, and there is also a good chance that a second treatment can get some good results, and the retreatment you can perform with similar parameters. But sometimes you have to make some enhancement in the settings, and that's important because it isn't a one treatment in every patient you want to treat. Sometimes you have to perform a second treatment, and in the literature, retreatment rates are reported up to 40%. And I will also give some examples about retreatments. So for example, if you treat the patient with the first treatment with the parameters you can see on this slide, the patient can get very good results. But sometimes the effect is becoming a little bit less significant after a couple of years. If this is the case, retreatment can be performed using the same parameters as the first treatment. And most of the time you can get some good results after a second treatment. But sometimes if you perform a first treatment, within the first 2 months, you don't get enough treatment effect. And then we know that you can make an enhancement. You can perform a second treatment. But in that case, you have to use some higher settings. So for example, in this case, you can increase the number of sweeps, or you can decrease the sweeping time, and you can go a little bit slower. And besides the settings, also the treatment technique is very important. So we know that you have to use some viscous fluid interface to let the probe make good contact with the ocular surface. You can use an eyelid speculum. Personally, I never use a speculum because I think in my hands, I've got some more freedom of movement with the probe without a speculum. But if you want to use a speculum, you can use it, of course. Most important thing is the probe orientation and the pressure you put on the probe. So it is necessary to make a good match of the probe with the limbal area. So the verniers of the probe, they have to be pointed toward the limbus. And during the treatment, you have to be sure that there is consistent pressure during the treatment delivery. And yeah, the sweep velocity is very slow. If you want to perform this treatment for the first or second time, 20 seconds sweep velocity or 30 seconds sweep velocity is very, very slow. This you have to make sure that the sweep velocity is also very good in order you want, if you want good results. And postoperative, I use some steroid drops and some NSAID drops. You can consider some cycloplegia, but I never use it. And in regard to the glaucoma medication, I always continue them. And if the eye pressure is lower, you can taper them during the postoperative visits. And the recommended follow-up visits, you can perform a visit 1 day, 1 week after the treatment, and 4 to 6 weeks after the treatment to see how the final result is. So in summary, we know that a MicroPulse TLT can give you very good outcomes 2 years after the treatment. It is very important to use the best settings you can use in a patient. So the minimum settings are mentioned here. It is also very important to adjust the power, the sweep velocity of the number of sweeps, depending on the severity of glaucoma or the intraocular pressure. And make sure that you use very proper treatment techniques in order to get some good results. Yeah, that was what I want to talk about.
Well, thank you so much, Ron. It was an excellent lecture. And now I would like to introduce Walid Zbiba. He's actually the head of the Department of Ophthalmology at Naboul, Tunisia, and a professor of ophthalmology at Tunis El Manar University. He integrated MicroPulse TLT into his armamentarium about 7 years ago, and he has since presented and published his experience with MicroPulse TLT. And today he will be focusing on describing his experience and his work on MicroPulse TLT in patients who underwent silicone oil placement and develop either ocular hypertension or glaucoma. Very important to mention that he is a trained vitreoretinal surgeon. So he does not only cause the problem, but he also fixes it. So it's going to be a pleasure just to listen to you, Walid, now. And thanks so much.
Thank you, Thomas, for the introduction. the introducing. So, hello everyone. It's my pleasure for me to be a part in this webinar today. MicroPulse technology has always been interesting for me, and since I am a very surgeon, I will focus today on the success and safety of MicroPulse DLT for silicone oil and induced ocular hypertension. So now I am talking from here, North Africa, Tunisia, near to Italy, surrounded by sea. Our story with Redex at our department started in 2017. We received this machine this year. We are the first department to have it on not only in Tunisia, but also in all Africa. We are proud to provide our patients a new weapon against ocular hypertension. So since 2017, we treated different types of glaucoma, more than 300 patients. And as you can see, the third had silicone oil-induced ocular hypertension. Why this is high number? In fact, our department is known for VR surgery, and we use silicone tamponade. This results in silicone oil-induced ocular hypertension. To treat this disease, we can begin with medical treatment, drops glaucoma, or we can do silicone removal, trabecuroplasty, or even invasive procedure like trabeculectomy or valves that are not very secure in this type of glaucoma. So here comes the MicroPulse DLT, an interesting and safe way to control high IOP. So we have published our survey about this topic in the Journal of Glaucoma in 2022. And we are still working on this topic with a longer follow-up, more than 3 years. So now let's start with a case of 40 years old patient who underwent vitrectomy with silicone tamponade for retinal detachment. 2 months after surgery, his IOP continued to increase despite maximal medical treatment. So we decide to treat with MicroPulse DLT. As we note, IOP was controlled with only 2 drops after MicroPulse, and even with only 1 drop after silicone removal. So let's move now with our study. So our study between 2017 and 2023, we include patients with no controlled IOP, non-observant, intolerant to eye drops. These are the baseline parameters that we collected. Our follow-up was extended to 5 years. The main age of our patient was 60 years. As we can see, this is a diagram to the decrease of IOP was maintained until 5 years. We have a low rate of side effects and complication. We mainly found conjunctival hyperemia in half of our patients. Now, if we compare patients in 2 groups before or after silicone removal, we did not find significant difference between the 2 groups regarding the clinical data. And there is no difference in IOP decreasing between the 2 groups until 1 year. A lower IOP after 1 year was observed in the group that had silicone removal. The same results for the IOP reduction rates. These 2 groups that have the same rate of reduction until 5 years. So the number of typical eye drops was almost the same in the 2 groups during the follow-up, with a decrease of the number of the medication along the follow-up. So we defined our success with when IOP is under 21. It is absolute if we have no treatment. We need no treatment. It's relative when we use treatment in this case. And we define the failure when IOP is more than 21 millimeters. It's relative when the reduction was more than 20% of IOP, and absolute when the reduction is less 20%. The success rate didn't change between the two groups at 1 year, neither at 3 years. But here it's an interesting sign. We also found a predictive sign of success of when the lower IOP at 1 month, the better is the success rate. Here, in my opinion, don't hesitate about retreatment in these cases. From our experience, MicroPulse TLT keeps the same rate in IOP decreasing as the first time. No significant correlation between age, gender, and success rate, and neither between number of drugs and success rates. Also between baseline IOP and success rate. Sorry. So, but we found a high correlation between the baseline IOP and the reduction rate in IOP at 1 year. If you conclude MicroPulse gives us a significant decrease in IOP in this disease, significant reduction in the number of glaucoma treatments, there is a correlation between the rate of decrease in IOP and the baseline IOP, a useful sign to detect a good response. IOP at 1 month is predictive of success. And we have no, for age and the gender are not predictive for the success. The presence of silicone or its removal and the duration of tamponade are not predictive of success in this case. So we recommend MicroPulse can be used useful in no controlled IOP or intolerance before or after silicone removal or even after surgery. Thank you.
Thank you so much, Walid.
So
great. So we have now, this was an excellent lecture, and I have a lot of questions that I want to ask you, Walid. I just want to let everyone know we have 15 more minutes for questions and answer. For those of you who want to stay, in the auditory and you want to, you have more questions, we will be able to stay a little bit longer and answer those questions. If I may start, Walid, with a question, right? I've had a case where, with silicone oil induced glaucoma, where I had the oil removed, but this had stayed in the eye for a long time, right? So there was a lot of emulsified, silicone oil floating around and already absorbed into the iris and the trabecular meshwork. And what we did back then is we removed the oil and then we did an AC washout, to remove as much as possible as we could. And we did a MicroPulse. The MicroPulse lasted, in that specific case, maybe like a year and a little bit longer. And the silicone oil continued to appear from I don't know where. So then we did like a second washout, a second session, and back then also a cataract removal. And a while after, I don't know if it was like 2 or 3 years, we did, the pressure actually went up again, and we did another washout of whatever was left, and we actually removed the trabecular meshwork. And since then, it's been a couple of years, the patient has been having pressures of 10 with, I think, 1 medicine. So I was really, this guy is a very close friend, actually. I was delighted by the outcome. But that, it came to my mind, the retreatment, option that you were mentioning, not being afraid of retreatment patients, expecting if you had a good like Ron was saying, if you had a good outcome initially, but the effect actually wore off over time, that if you repeat it, you would have also like a similar, IOP lowering effect. And also combining strategies just to try to get, more silicone oil out. If you, for some reason, decide to do, a trabeculectomy or put a valve, the less silicone oil you have inside of the eye, the better. And like Ron was saying, MicroPulse could also be that bridge, to be able to get all those little emulsified bubbles before you do that other surgery. What do you guys think about that?
So first of all, when there is an increasing hypertension after vitrectomy, there is two types of hypertension after vitrectomy. Hypertension, it depends directly from the surgery. Vitrectomy can cause hypertension. So we have to treat with medication. If we can fix this problem, it's enough. And if the hypertension increase and until 2 months, 3 months, we can use MicroPulse. So when we silicone removal, the silicone removal must be indicated up to 6 months. If we do this after 6 months, the risk of emulsification of silicone is increasing. So we have to avoid to remove silicone after this date. So in this my practice in our department. We don't. We have to remove silicone after maximum 6 months when we use this case, because when we have emulsification, it will be very difficult to fix this hypertension, as you say. There is a lot of emulsification. They comes from the cavity, and there is a relica of vitreous in the basis. This relica of vitreous caps emulsification, and there is a relegation of emulsification each movement of the eye. So that's why, and the emulsification attack the denaturate the meshwork trabecular. So that's why there is a trabeculate in same, if you can see, with this emulsification.
Mm-hmm. Yeah, that's what happened to this patient.
And not hesitate to retreat with the MicroPulse.
That I wanted to ask Ron, since you're, you have such a long, follow up of patients on who you've performed. I was seeing up to like in 50% of your patients of your series, you did like a retreatment. So I had like two questions for you, Ron. On one side, with one treatment, I mean, you've seen patients for a long time now, 7 years of doing MicroPulse, right? 50% of those patients did not require a retreatment.
Yes.
And so when I ask you, so how long can MicroPulse TLT last? It's like asking you SLT, right? When I tell my patients it could last for years or it could last for months. So that's my question my answer for SLT. So what will be your answer to that same question when it comes to MicroPulse TLT?
Yeah, that's a very good question. If we look at the literature and also at our own data, and we see that the highest chance of a retreatment is in the first year. And that's most of the time where the period in which you want to see what is the effect of a treatment, and in order you can perform a second treatment to get a final effect of a treatment. So for example, I think the retreatment rate in the first year in our patient population is around 30%, 35%, something like that. And if we look at the retreatment rate at, for example, 3, 4, 5 years, it's 40%. So most of the patients require a retreatment, if they require a retreatment, in the first year. And most of the time that is for enhancement or retreatment. It depends on the effect. We've got also a lot of patients in which a first treatment has a very good response. You've got a lower IOP, you've got a reduction in medications, but you want some more effect. And this could also be a reason to perform an extra treatment, to perform more treatment effect. And for example, in our for example, in our published study, half of the retreatments were performed in patients who already received a treatment success after first treatment. So they were successful. They had more than 20% IOP reduction or medication reduction, and we just want some more effect on it. So yeah, I think if the first year the pressure is good, the IOP is good, I think that is the most important thing. And then there is a higher chance that the effect will long afterwards. But we have to get more data about it.
On the consensus, I remember that we tried to separate what's a retreatment versus an enhancement, right? Yeah. And you were mentioning that on people that you were getting a successful initial treatment and the pressure would have remained, you know, above 20% reduction, you would do an enhancement and get an additional pressure reduction, right? I think there was a publication, I don't remember the author now, but they were talking about like a 16% extra pressure reduction when an enhancement was performed. So Walid, one question that I forgot to ask you, you know, those patients that you're describing, especially those that go beyond, I don't know, 3 months or 6 months of having ocular hypertension secondary to the silicone oil, those are kind of considered advanced cases of glaucoma because the outflow system is really damaged. What are the settings you're currently doing in order to achieve good pressure reduction? And Ron, this is something I wanted to ask you, you know, I'm asking both of you. You know, when it comes to the setting, this is something we need to tailor depending on the clinical scenario that we are approaching, right? That's very, very important, right? I mean, you don't want to do like very starting settings on someone with moderate or advanced glaucoma, right? You probably reserve that for, you know, people who are just pretty in good shape and you need that extra pressure reduction. But for Walid patients, I mean, what do you use to get, you know, those pressure reductions?
Thanks for the question. It's a good question. So I begin first with, as said Ronald, a little bit of time of sweep, 20 seconds per sweep. So I remark that there is no result. So in this case, I use even 5 sweeps, 10 seconds per quadrant sweep. So each quadrant 50 seconds. In total, I do 200 seconds for the whole circumference. So and if it's not enough in the second, I increase the contacts with the sclera. So I increase my contact with 15 seconds per quadrant in 4 sweeps.
Okay, so you're going from 20-second sweeps, you know, per hemisphere to 30-second sweeps per hemisphere, really. I mean, or you want to call it like from 10 seconds per quadrant to 15 seconds per quadrant, right? Yes. And you remain with it. You're using the revised probe, correct?
Yes, the Rev 2, yes. The new one.
Rev 2? Yes. Okay. This is the one that most of us are actually using.
But in 16, in 17 and 18, I used the old one, so.
The original, yes. But I mean, those are the settings you're using nowadays on your patients. So, you know, Ron, what are you doing with your current patients?
Yeah, for example, if you've got a patient with a secondary glaucoma after vitrectomy, I use 2,500 milliwatts, sweep time of 20 seconds per hemisphere. and 6 to 8 sweeps per hemisphere.
All right, you increased on that side. You went from the 4 to 5 sweeps of the consensus to 6 to 8.
Yeah, because I like to have a good effect. And most of the time, the higher the pressure, the more sweeps I do. And for example, secondary glaucomas after vitrectomy, most of the time they can make very high intraocular pressures. So for that type of patients, I like 6, 7, or 8 sweeps of 20-second sweeping time per hemisphere.
All right, so this is for most of the patients. This is your starting, settings, right? That's very important to clarify. Because on the consensus we were seeing, those settings like the 20 seconds, 4 sweeps, 2.5 of power were starting, but it was really for more like mild glaucomas, healthier eyes. What we use for as glaucoma specialists or retina specialists, for more hardcore patients, our settings are a little bit higher than that, as we just all described, right? And I had a question that it's becoming like a hot topic out there. Combining procedures like MicroPulse with angle surgery, cataract surgery. What are your thoughts there? Anyone?
Yes, I have an experience with both combined surgery, glaucoma and cataract surgery. So fellows asked me a lot why we did MicroPulse after cataract surgery. Why we did not before opening the ocular globe. So first of all, when we use the probe and the MicroPulse, there is a tension on the zonular, because there is a contraction of the muscle of the ciliary body. So when we use the probe into the eye and we manage the nucleus, we have a high risk to zonular rupture. So that's why I recommend for my fellow to do cataract surgery, make stitch in each incision, and after that we do MicroPulse treatment. After the surgery, we have to increase the number of drops after surgery, because there is a higher rate of inflammation. So instead 4, we have to add 8 for a long time, for 10 days or more, to control the inflammation. This is I have not a lot of experience. I did I think 40 cases, but I know that there is a lot of inflammation after cataract surgery.
40 cases, it's a pretty good number to get impressions, right? So my question, there's not too much.
I did my grandma.
Wow. And so my question for you here is, like, I know there is not that much publications out there
Yes,
describing.
I have
No, but on your experience on those 40 cases, we know that for many patients on whom we do cataract surgery alone, we are able to decrease pressure. From a mechanism of action standpoint, MicroPulse TLT could potentially have a synergistic effect, with other procedures like cataract surgery in order to lower pressure. Has it been your impression that you're getting more of a pressure reduction when you combine both procedures than if you just do cataract surgery or just MicroPulse? What makes you decide to combine both procedures?
The time. We have a lot of number of patients, so this is organization time. So we have to do the same surgery in the same time, because we can't program this. This is why. So
it's cost effective, basically.
Yes.
Terrific.
Especially. but 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 I but I don't think there is a lower oppression after I don't I don't know this after surgery, really.
Okay, but you're getting a good pressure reduction. I mean,
Yes,
when
I
you're
could
combining both and you're not getting extra side
about
effects
40%.
besides inflammation, that you treat more aggressively.
Yes, I treat more aggressively the inflammation, but the
Okay,
lower pressure is good. We have a lower pressure. Yes, we have a good control of the IOP after the surgery.
and when it comes to visual acuity, anything that it has been described that in a percentage of patients on whom you do MicroPulse, you could get potentially a decrease in visual acuity, even though some have said that that's related to progression of cataracts or like some dry eye that you develop over time. But in your cohort of patients, have you seen any impact on visual acuity from the MicroPulse?
No more macro edema. If you pose this question, no more macro edema. No, there is no increase of the macro edema. So it's especially inflammation. It spent 10 days, and after that, it resolves with a good medication, aggressive anti-inflammatory medication. Enough. That's enough.
Which is mostly topical steroids.
Yes, topical steroid. Yes.
Yeah. Ron, anything you want to mention on this?
No, I think I've done some combined cases, and I think you can perform it safely, and you can get some good results. But we also do some other combined procedures with cataracts, some other minimal invasive glaucoma surgeries. So I prefer MicroPulse as a standalone procedure.
Okay, great. There are like 16. Yeah, go ahead.
You did only one procedure per day, Graham?
Sorry?
You did one procedure, not combined. You prefer not combined. You don't.
It depends on your patients. It depends on your patients. We've got a lot of patients who are already pseudophakic. And for example, the patients in which we are performing, the glaucoma patients in which we perform cataract surgery, we combine them more often with, for example, an iStent or an Elias excimer laser. So we do a lot of standalone MicroPulse treatments.
Okay, thank you.
So we are already on time. It's 4 minutes past the hour. But if you guys are available to stay like a couple more minutes, we have several questions from the audience. Okay, so I'm just gonna go from top to bottom here. Is there any difference between discrete or spot treatment with respect to inducing choroidal effusions? I think like we were saying before, when it comes to, I think you're referring to sweeps or discrete spots, right? Discrete spots is what you do with traditional CPC. And like we were saying, you're blasting the ciliary body, you're using a lot of energy. So there's certainly going to be more inflammation. With the sweeps, actually, the study that I was referring to during my presentation was on MicroPulse TLT. And they said up to 50% would develop some sort of choroidal effusion. I don't have data on that measurement with traditional CPC, but I would think that because of the magnitude of the energy they're using, it should be similar or maybe a little bit worse. Though with traditional CPC, you don't treat the entire eye. With MicroPulse, you're really, the only areas that you're avoiding usually are 3 and 9 o'clock, and also areas of thinning or excess melanin, or a trap, right? But with traditional CPC, usually you treat 2 or 3 quadrants, you spare some. So that's the answer I can give you, Shabir, about your question. The next one is from Shana. what do you think is the time frame for each of the IOP lowering mechanisms to begin to operate? And when is it realistic to evaluate the final hypotensive effect of MicroPulse CPC? TLT, that's a great question. And on the consensus, which for those of you who may not be familiar with those two publications, those are guidelines that we published back in 2021 and 22. It was a consensus expert, a consensus of experts. We did a Delphi process to try to come up with answers to most of the questions we all had. And one of the questions was, when do you, the same one you just asked. So when do you expect the maximum effect or the durable effect of MicroPulse TLT? And the consensus was that it could take up to 6 weeks. Why? Because you wanna make sure that you're off steroids, so there is no steroid response affecting your outcomes, and you're also giving time for the ciliary body to have some fibrosis, or at least the inflammatory changes to settle down more, right? Usually by 6 weeks, there is no more inflammation, at least that you can see on the AC. So even to make a decision on what to do next, if for some reason, you're anxious about maybe having to perform a different or an enhancement or whatever, you wait at least, 6 weeks, if not longer. And when it comes to the mechanisms, I think, the inflammation in the eye, the enhancement on the uvea at the very beginning is very immediate, and just immediately after the treatment, within that first week. The potential pulling on the scleral spur, there is no reason why, if it happens really and has an impact, why it would not happen, immediately. But it takes time for fibrosis to develop, right? For the metalloproteinases to act, and that enhancement on the uveoscleral outflow would actually take longer. So the next question, this is probably for you, Walid. It's MicroPulse CPC effective in neovascular glaucoma with high IOP, and what are your settings? So here they're actually talking not about MicroPulse TLT. Well, actually, I don't know. Well, maybe, you spoke already about the effects of MicroPulse. Well, yeah, it's not clear from the question if he's referring to MicroPulse TLT or just CPC. But how was your experience with MicroPulse TLT on neovascular glaucoma patients?
So in this kind of glaucoma, it's often a severe glaucoma. So in this kind, I combined CPC and MicroPulse. So I tried to combine these two types of laser, continuous one and MicroPulse one. So I did the 360 with the MicroPulse TLT, and I did six spots of CPC in each quadrant, 2 in each quadrant. So we have 8 or 6 impact of CPC to control the IOP, the higher IOP. It's my opinion, but it's not very useful.
No, what you're saying, a lot of people actually do that when it comes to treating cases so difficult, like a neovascular glaucoma patient that has SIP closed the entire outflow system. What are your settings? For the MicroPulse part, we know, I guess it's similar to what you use for your silicone oil patients, but what about the spots that you do? How do you do those spots? Those two spots of each quadrant.
In each quadrant, I do two spots, 2 impact in each quadrant. So, and we have to and the pop, and we
Oh,
have
you look for the pop?
yes.
Oh, okay.
You
All right,
have
so you're using like you're using a different probe. You're using the G probe,
yes. I use the two prop, the G
two
probe one.
probes.
Yes, two props.
Okay, all right. So you do
First
just
prop.
traditional CPC,
And
two
after that,
spots. You go down after you hear the pop.
yes.
Okay, and what are you satisfied with your outcomes when you do that technique?
So I I um, I can decrease the IOP, but not enough.
So
It's
you mean
not enough. It's very difficult when we have this kind of glaucoma, severe glaucoma. It's very difficult to treat this. Yes, I have a lot of problem with this kind of glaucoma, neovascular glaucoma.
yeah. Also, when you did traditional CPC in the past, results were similar, right? I mean, they're a little bit all over the place.
Yes, it's a complication. Yes.
Yeah, but I mean, certainly you have to be more aggressive with those patients, and it will likely,
So
you know,
with MPTLT, I do 5 sweeps, each sweep 15 seconds.
okay,
Okay,
per quadrant, right?
per quadrant, yes, per
Per
quadrant.
quadrant. Okay, yeah. So you do a high dose MicroPulse, and
yes,
you
high dose.
enhance it with CPC. Ron, do you have any comments on that?
Yeah, I never combine the both treatments at the same treatment. So, for example, if I've got a patient with neovascular glaucoma, most of the time I always start with MicroPulse treatment, but with very high settings. So, for example, 20 seconds sweep time per hemisphere and 7 to 8 sweeps per hemisphere, just to start with. And you can see what the effect is afterwards. And if you see a good result, you can do a second treatment with MicroPulse if treatment effect fades away. If I don't see a good result after a first treatment with high settings, I move over to a continuous wave mode.
Okay. I just to complement what you guys are saying, I kind of like to see at what stage of neovascular glaucoma the patient is. Sometimes it's still like open, but it hasn't really contracted the membrane on the angle. And I think that has an impact on the outcomes. But also if I'm able to put a valve in, right, I think that's also a very viable option. And sometimes I've had the need to enhance the effect of the valve by doing MicroPulse after, right? So that could also be a combination, just to use those two tools to manage those very difficult cases, right? That sometimes with one procedure are not, controlled. And here we have a question. Has anyone noticed perilimbal circumcorneal conjunctiva adhesions post MicroPulse TLT? I don't know if he's referring to synechia in the anterior chamber or just scarring of the conjunctiva. I haven't been impressed by neither of them after MicroPulse. What about you guys? Scarring on the conjunctiva after MicroPulse?
Scarring with the conjunctiva, I note this when we have hemorrhage under the conjunctiva, or when we have nevus under the conjunctiva, or we have melanin of the conjunctiva strip booked in the conjunctiva. When we pass up to this type of zone, there is a captation of the laser, so there is a burn of this location. That's why they have this. If we avoid these places, this zone, we don't have burns.
Yeah, absolutely. I mean, on our consensus, like melanin, hemoglobin, those are chromophores that will absorb the laser in the wrong place. And
Yes.
like you're saying, it will actually cause the scarring. So probably the recommendation is really to try to avoid that. You know, we use vasoconstrictors, you know, before we do the procedure, just to minimize the amount of hyperemia. That's not always possible, of course. If there is a lot of melanin, you know, in order to avoid conjunctival burns, we need to be aware and minimize, you know, the melanin, the hemoglobin, povidone, you know, whatever it's in there that can absorb the laser. Okay, and you know, we're almost there here with the questions. Do you have any experience with MicroPulse TLT? Well, yeah, this question was already asked. Since the temperature stays low, why is the treatment so painful? All right, Ron, do you want to answer that, or anyone?
No, I think it depends on the anesthetics you use. And that's one important thing. And it's still the treatment area is still around the ciliary body. So we know that's a very painful area. And I always use a subtenance anesthetic block. And in my practice, treatment is never painful. So it depends, I think, a little bit also on the type of anesthetics you use.
Yeah, it's important to clarify, like for traditional CPC, because there's so much damage, you know, you should be aware of pain, I mean, during the procedure and after the procedure. For MicroPulse TLT, the evidence has shown that the patient almost never, I mean, very rarely would have pain after the procedure. But during the procedure, there's going to be a ciliary spasm, and that's painful. And that's the reason why during those 5 minutes that you're doing the procedure, the patient needs to have some sort of anesthesia, you know, like Ron was actually mentioning. But the source of the pain is actually the spasm of the muscle. And that goes a little bit in alignment with Jonestone's, you know, video that actually shows the contraction of the muscle, right? It's a very intense, painful contraction. Now, after how many sessions? This is more for you, Ron. After how many sessions of unsuccessful, we have to shift to other treatments. So, I mean, over the years, well, can you tell us when you actually stopped doing retreatments or enhancements and you just move on to a different procedure?
Yeah, if a patient doesn't have a good response, I always perform a second treatment. If a second treatment doesn't show a very good result, I shift to another treatment.
Good.
And otherwise, it's just a little bit like an SLT. If a patient has a good response and after a couple of months or years, the effect goes away diminish, you can perform a second treatment. And also after, for example, 2 or 3 years, if the effect becomes less, you can still perform a third treatment. So if a MicroPulse treatment isn't successful, I always perform a second treatment. Is a second treatment not successful, I shift to another treatment. But it also depends, of course, on the progression rate and the intraocular pressure level. But if you've got time, I always try to perform 2 treatments before I shift to another treatment.
Ron, what is the maximum times we can retreat? That's a question from Alka.
It depends just a little bit, like I just mentioned. So it depends on how long that the treatment effect lasts. So for example, if a treatment effect lasts more than 6 to 12 months, I perform a retreatment if necessary. If it's lasts for shorter, I shift to another treatment. But for example, I think I've got 1 or 2 patients in which I performed 4 treatments, something like that.
All right. Okay. So, I mean, doing 2 or 3 treatments would be acceptable, you know,
Yeah,
from
for
your
example,
experience.
if you perform a treatment and 2 years after that the effect fades away, you can still perform a second treatment. And also after that, if an effect fades away after 2 or 3 years, you can still perform a third treatment. So it depends a little bit on how long the effect is existing after a treatment. If its effect is lasting 3 months, and you perform a second treatment, and the effects after a second treatment still last again for 3 months, yeah, you have to think if another treatment is more appropriate for that patient.
Great, thanks. Just for the audience, I'm skipping some of the questions because we have already answered them to some extent. Here, when it comes to myopic patients, Julita is asking, if you change your settings or technique when you treat highly myopic patients. I mean, the only thing that I do different, I mean, sclera is supposed to be thinner, so there's going to be probably more transduction of energy. I don't think that it will have such a great impact, so I don't change my settings on that. Though I sometimes transilluminate or do a UVM just to get a better idea of where the ciliary body is placed. I don't know if any one of you guys do something extra for highly myope patients.
Not for me. I use the same parameters for myopia, so I don't. It depends on the severity of the glaucoma.
Great. Congenital glaucoma.
No, I have congenital. I don't think it's very useful to use this kind of treatment in congenital glaucoma. For me, in my experience, I use this, and I think because the angle is the trabecular meshwork is not normal, so it doesn't be a good effect on this type of glaucoma.
Yeah,
I
Ron?
in my experience, I don't know what about you, Thomas, or
Yeah, I think there is a difference if you want to treat congenital glaucoma in a child or congenital glaucoma in an adult person. I think that are two different ways. So for performing MicroPulse treatments in very small children or in young adolescents, we don't have a lot of data of it. For adults with congenital glaucoma, I performed MicroPulse TLT.
Yeah, I agree with you, Ron. Actually, the literature on small kids with congenital glaucoma supports Walid's findings. It's tough. It's the results are very ambiguous. The literature
Sometimes,
still supportive, actually.
especially for young adolescents, you can use it for bridging some periods. So in that way, we use it sometimes in children from 15, 16, 17 years old, something like that.
Mm-hmm. Good. In your experience, how long will it take between TLT reapplications? Could we say to apply every 5 years? I think you've answered that, Ron, at extent. Just Ron, one quick question. When you actually escalate, what do? You go from what to what, roughly? So 25% up, right? So well, just to give an example for us.
Good result. More than 1 year existing effect. I use the same parameters as the primary treatment. If I don't have a good response, I go up, for example, with a couple of sweeps. So if the treatment doesn't show a very good result after a first treatment, I decrease my velocity of the sweep movement. So I go from 20 seconds up to 30 seconds, or I adjust the number of sweeps with still performing the same sweep velocity.
Yeah, great. And just to reinforce this, what is the minimum time in between treatments you wait?
I think
4 to 6 weeks.
6 weeks.
4 to 6 weeks. I think on the consensus we suggested a little bit longer, right?
No, I think it also depends on how long that you use the steroids. For example, if you use steroids for 4 weeks, I should definitely wait 6 to 8 weeks before you consider a retreatment. We only give post-operative steroids for 2 weeks. So if a patient comes 4 or 5 weeks after a treatment, most of the time, that's the treatment effect the patient will show. So if a second treatment is necessary, I schedule it in around 6, 7, 8 weeks after the first treatment.
This is a great question from Philip here. I have observed reduced corneal sensation. We are almost done, right, with the questions, maybe 5 more minutes, but I have observed that the questions are so good that, you know, it's just tempting to stay longer here. I have observed reduced corneal sensation and a couple of corneal ulcers that that take actually a while to recover. And I would love to hear you, Walid, you know, when you do, you know, your eyes, I mean, you've done retinal detachment repair, you know, the paratomies, put the conjunctiva back in place. You just ruined all those stem cells and globate cells. Have you seen like neurotrophic ulcers or a severe dry eye after performing your MicroPulse procedures?
I think MicroPulse preserve surface because as you know, medical drops attacks and surface and is not good for the surface. But when we use MicroPulse TLT, we decrease the number of drops, and if we decrease the number, we save the surface. And I did a survey, and it will be in published. I take a sample of, I did, first of all, MPTLT. After that, I give a sample of conjunctiva. And we see if there is inflammation in the conjunctiva or fibrosis. It increases of the inflammation or the fibrosis. We note that there is no fibrosis and there is no inflammation in the conjunctiva after MPTLT. So it's a good finding. What we find in this survey is our survey, and it enhanced that MPTLT saved the surface.
Well, maybe to some extent it could affect the nerves.
What?
In some cases, I mean, I've had like actually throughout all this 8 years, 2 cases where in one case, the patient was almost 90 years old and I did the CPC and he had a severe dry eye for, you know, 1 or 2 months that just resolved on its own with intense lubrication. That was one. And then I had another guy who actually had silicone oil-induced glaucoma and multiple retina surgeries on whom I got a little neurotrophic ulcer that I managed with, you know, a contact lens. But again, it's 2 cases throughout my MicroPulse TLT career.
We can in these cases we can incriminate the MicroPulse TLT or the CPC because these eyes are they have a multi-surgery, so vitrectomy, desenceration of the conjunctiva, and a lot of medication. So there is a lot of aggression of the surface. So we can't relate to this dry eye with MicroPulse TLT or CPC because the target of the CPC or the MicroPulse TLT is the ciliary body. So I don't think so. There is a relationship between the surface and this kind of treatment. So in my opinion, and according my survey, the MicroPulse TLT save the surface. I think save the surface. It's my opinion, and it will be published as soon as possible.
Right. And the last question from Carlos: any impact of MicroPulse TLT on the endothelium? Anyone?
I did this. I did the same in the same survey. I did the OCT, and for the pachymeter of the thickness of the cornea, there is no relationship between the TLT and the cornea. So it's very safe. MP TLT is safe for the surface and either for the cornea.
Yeah, I am personally not familiar, or I don't remember actually if in the literature there is a description on the endothelial cell count before and after MicroPulse TLT. Not that I remember. So, my reply would be also consistent with Walid. I mean, there is no change on the pachymetry, but you may actually lose cells without an impact on the thickness, but at least grossly, you're saying it's fine. And from what I remember from the literature and from my own patients, I haven't encountered that issue, even though I don't recall a paper measuring, but it may be published. It may be there, measuring endothelial cell count.
If you want, I will send you my data and we can discuss with each other about this data, about the pachymetry and the OCT of the anterior chamber and the microscope, specular microscope of
Oh,
the
okay. Oh, great. And now I'm being told by someone that actually there is a paper that showed no increased risk of endothelial cell loss. So I think we covered that question. And that was the last question. For me, it's been an enlightening webinar, guys. Any final remarks, comments here? Ron?
No, I think it was, we've discussed a lot of topics about the MicroPulse treatment, so I've got no additional comments.
Okay, Walid?
So no remarks. Thank you for this webinar, for this meeting. Nice to meet you, everyone.
Well, it's been a pleasure. Thank you everyone for joining us. Thank you, Walid. Thank you, Ron, for being here. Thank you, Iridex, for facilitating it. And I hope this was an enlightening webinar for everyone involved. At least it was for me. Thank you. Bye-bye.
Bye.